tiny bit of the care system, we can then back up into the
Exactly.
Just going to read the stone. And they are on bones.
Lee, do you have the printed briefing? Do you have the briefing at all? Sorry, I should have brought one with me.
Sorry, no,
Thank you. Did you manage to decide what you're going to say?
Let's see. Did sleep all night. I took my cat to close the window in my bedroom,
Oh, no.
and it was like, I was like, it's the freezer.
Yeah.
And then I think it was like, you have to sleep, so then you can't sleep.
Yeah.
So I was getting so stressed.
Right. Okay.
It's like 8 and I was like,
Have you got a break from that?
and I've got like your obesity thing tomorrow. Yeah, the torture me.
It's going to be great. Redefine obesity policy. New era. Thank you. Would anyone like a speaker briefing?
Yeah.
There we go.
Let's just somehow lose my scripture on the way here, but anyway, hopefully it'll resurface. That's water would be grand.
I think it's just coming.
Oh, cool. Actually, sent a Sonia. You're Sonia from.
I'm a doctor.
Oh, okay. I saw you on the. Yeah. Cool.
And you're Charlotte.
That's right. Where you live?
In Tottenham.
Oh, okay, cool.
And where do you
I live in Lambeth.
Yeah,
I've got that. Have you got the program with
I think really, if I was a winner, I would find that quite nicely reassuring. I don't think they're here for art. Let's try it.
totally misunderstanding the complex. It's just
When I saw these funny pens, I was thinking, oh, maybe it's like COVID. No,
having as many people in
so I was thinking maybe it's one of those things, where they're in there or
the opposite of COVID.
then I should bring a mask, but it's so
Unless your policy is extended down in 10 years, but that's not
It was last over after.
A friend of mine got a boring COVID. That's it.
Yeah. Yeah. Some of that pacing might not be. It's hard to say if it's compliance is always policy. I wonder if it might lead up, but I agree that's the real test.
Shall I see some water? I said Charlotte come to get some water.
Molly said it was bringing some.
I'll try to catch part of this person's eye. Someone was going to get some, but I think we're having trouble with the logistics.
So,
Yeah,
it's just gonna get going, I'm sure.
Ollie, your water. Right. What should we say? Should we say 16 seconds? 22?
Start at 22.
Hi everyone, we'll just start at 22, so just 2 more minutes.
New GP.
Here it comes.
You'll be impressed.
I always think no one wants the speaker to fail. No one wants the speaker to like flatter. So they all want to do that. Yeah.
So health county, it's about 2 years old.
I was gonna say, and actually, it's a lot of the holes and stuff like that, and school stuff is easier.
Yeah, so
Some of the stuff with employers.
they have the school councillors pledged in the previous school, but that seems to have gone pretty fast. This has been a mental health pledge, not that.
Yeah, no, exactly, which I think is just a mistake, because it's much more open to counter
Speaking just after you.
that has a bit resonance.
Yeah, I totally agree.
Is this the order? No. I'm bed. Just mentally prepared.
I'm going to go right to that.
To go to Charlotte.
Charlotte's.
I'm sorry.
Well, I'll do a little spiel as well.
Okay.
Oh, these the same.
Yeah, we're trying to make sure that when she hear like talking speakers.
So the empty chair goes last.
Okay. Where is the end? Oh, you've got a chair
Got to
there.
give Rachel a standing ovation. She doesn't need it. Let me see. Okay, I think that's how we'll get started. Hi everyone. I think we'll make a start. We will be joined by West Streeting just as soon as Rachel Reeves' speech finishes in the main hall. A big welcome and thank you for joining us today for what I think is one of the most important conversations we could be having. I'm Chris. I'm head of the Commission on Health and Prosperity at IPPR. And I'll start by saying a big thanks to Engage Britain, who are co-hosting this event with us today. Let's start with a little bit of context. So we're having this conversation with the NHS in perhaps its most desperate state since it was formed in 1948. We have 7 million on waiting lists. We have 30,000 waiting 12 hours in A&E in the month of July for more than 12 hours, a shocking wait. 1.2 million waiting for community mental health services. It's a huge crisis, but equally, we can't think that that's a particularly new crisis either. Whilst the COVID-19 pandemic was indisputably disruptive, it wasn't the beginning of the trends that we're seeing now in the decline of the standards of our health and care services. Between 2010 and 2019, we saw the number of 1 year waiters, people waiting more than a year for elective treatment tripling. We saw us going from a state where we regularly met cancer targets to a state where we almost always missed them. We saw the maintenance backlog in the NHS estate rocket to huge highs, and we saw hospitals lose both their capacity for safe staffing and for safe occupancy. And on the eve of the COVID-19 pandemic, most hospitals across the country had levels of occupancy that are considered above the safe level, making it incredibly difficult to manage demands in spikes in demand. So we need a plan. we need to revitalise a public service that is hugely popular. And despite all the challenges that I've just talked about, polling and the British Attitude Survey and every other piece of evidence that we have suggests that those founding principles, those core principles of the NHS remain incredibly popular across the population, across Conservative, Labour, other party voters. And it's increasingly clear that we need to do that for the human cause, for the democratic cause, because it is so popular, but also for the prosperity clause, because it's so important. Health is so important to growth, to productivity, to fairness in our economy, the things that we really care about from an economic perspective. So where should we look? How do we define that plan? Well, this conversation today is about starting with the views of people, of citizens, people who depend on services, who use services, who staff services, people who care about and use the health and care services that we have in this country. And I'm delighted to be joined by panelists that are absolutely at the forefront of understanding what that citizen-led approach to service reform looks like. So from right to left, joined by Charlotte Augst, Chief Executive of National Voices, coalition of patient organisations doing hugely powerful work. Dr. Sonia Adesara, GP and activist, so working in frontline services. Julian McCrae, Director of Engage Britain, who have been doing exciting deliberative research on what people want and understanding those views, which I'm sure we'll hear a little bit more about in a couple of minutes. So in terms of the format, I'm going to invite each to share some of their thoughts, to give a little bit of a prompt or provocation. We'll have a little bit of a discussion. We'll come to you for questions, and hopefully we get some way to pinning down what the next steps need to look like to reforming health and care services in a time of desperate need. So Charlotte, could I start with you?
Yeah, thank you, Chris. I think if we want to take seriously the idea that citizens and people and communities, and particularly those who carry high burdens of disability, ill health, impairment, that they should be the forefront of making decisions about health and care, then we need to get into the habit of asking better questions of them. And I'm really looking forward to Julian's presentation, because I know they've taken that very seriously, and I've asked some good questions and asked them in good ways. I think too often we go to the public and say, do you want a pharmacist in primary care? Do you want a GP in A&E? Do you want to go to a minor injury unit, or do you want to go to an A&E? And all of those are sort of questions that straddle uncomfortably people's frustrations with what's going on, with some half-cooked solutions to what might help. And I think you then often get answers, at least in my experience, that run a little bit like, the NHS isn't working properly because it's got too many managers, and we need more doctors. And also, I think, sadly, we often hear when we ask questions about why is the NHS struggling, that we need to stop migrants from using the NHS. So I think if we ask dumb questions, we're probably going to get dumb answers. I have spent, some years of my career listening to people and their organizations about, what do you actually want from health and care? What would a system that worked for you actually look like? And lo and behold, people have actually very few ideas or thoughts or insight or interest in the wiring on the back of the health system. And I don't have an interest in the wiring on the back of the British rail system. I don't. I just want certain things delivered to me. And sadly, this morning they didn't include coffee on the train. But I don't know really how long the franchise runs for, or I don't even know really how it works. And I think most people feel like that about the health system. But people have, I think now that I've listened to so many stories and so many complaints and so many ideas, I would summarize it that there is 3 ideas people want to see realized in health and care, plus 1. So the first one is, people want the health and care system to get upstream. People want proactive outreach before things get really bad. People often know that they're on a trajectory of decline if nothing happens. people who have chronic conditions, people who have recurrent conditions, they know what it looks like when things get bad. And they want help then. They don't want to wait until they're fallen over. And they also, I think, quite intuitively understand that that's better for the system too, to help someone as they begin to feel funny about food, as a young woman begins to stop eating. It's better to intervene at that point than for her to seek help and be told you're not skeletal enough, you're not anorexic enough, come back when you lost another 3 stone. It just doesn't make sense to people that we wait for things to get really bad. And so people are interested in the idea of health creation. And they're not just interested in that idea for the super fit. They're not just interested in that for people who are currently totally unencumbered by ill health. They understand. Shall we let Wes Street first, or do you want me to continue?
Please keep going.
Hi, Wes. They understand that there's still a lot to play for. When you've got your first condition, which, as we all know, poor people often acquire earlier, there's still a lot to play for. Just because you've now got sore knees doesn't mean you also need to lose your job and also get depression. So people are really interested in early intervention and prevention. The second thing people are always really interested in, and that's the thing that often is reflected in the newspapers and the way politics talks about health and care, they're interested in access. And they want that access to be, they want to be given choice. And they want that access to be easy, and they want to be able to understand the rules. And I think fairness comes into that quite strongly in how people think about access. One thing that always struck me was when you talk to people who are really quite excluded from health and care services, people who really struggle with using health and care, they often speak quite fondly of their pharmacy or of a pharmacy locally. For example, when we spoke to travelers, they said that's where they go for their healthcare needs. And I think, and we've unpacked this a little bit, it's often to do with the fact that you can see how it works. There's a door, you walk through it, there's a health professional, and you can ask them some questions. They're highly trained people, they bring the health service into the conversation. And I think that's what we've lost with the proliferation of access initiatives. People don't understand anymore how to get hold of anyone. And the only other place where something like that's replicated is A&E. And so I'm not surprised that that's where people often gravitate. So people want health creation, people want access. And thirdly, when they're in, and that's something we hear less about in the media, they want joined up holistic care. They couldn't care less whether this bit is social, this bit is primary, this bit is secondary, this bit is specialist, this bit is elective. Does not make any sense. They want who they speak to know all their interactions with the health and care system. And they want that interaction to be about their needs in the round. And lo and behold, that includes mental and physical health needs. So I think the division we have created between mental and physical health systems really doesn't work for people. And they wanted to straddle their medical and their non-medical needs. If you have an acute illness, you often have also very sudden non-medical needs, emotional needs, financial needs. My husband was diagnosed with terminal cancer some years ago, and it's a massive, massive shock when that happens to you. And literally the first thing that kept me awake at night was obviously thinking about what was going to happen to him and his health, but how am I going to pay the mortgage? That is a very obvious thing you ask yourself. So medical and non-medical needs need to be thought of together. And then my plus one, so those are my 3: health creation, access, and holistic and joined up treatment. And my plus one is people want equality in this. People have a very strong sense that the health system needs to reach those people first who are least able to advocate for themselves. And sometimes that's because of stigma and discrimination, and sometimes that's because of lower literacy, and sometimes that's because they don't understand what's wrong with them in the first place or how the health system should work. People are very sympathetic to the idea that the person who has the most urgent needs should be seen first. This is not a counterintuitive idea for people. And I think we have a lot to play for around the idea of equality and fairness in that. So those are the things I hear over and over again when I speak to people. And I wonder how that resonates with what other people around the table have got to say. Thank you.
Thank you, Charlotte. It's always hugely insightful to hear your thoughts. And I think that's a really compelling set of principles for us to take forward and think about. We're joined by Wes Streeting, Shadow Secretary of State for Health and Social Care. Wes, a really big announcement just now in the hall, which is exciting. Maybe if I come to you next off the back of it to hear your thoughts.
Yeah, so it was very much worth my while being late coming here, I'm pleased to say. So as I alluded to this morning, for those of you who were at the Institute for Government event, if IPPR don't mind me mentioning, you know, without a plan for the workforce, there is no plan for the NHS. That was the big hole in the heart of what the new health secretary said in her very shallow Sesame Street statement last week with the ABCD. It's all very well listing, you know, doctors and dentists and ambulances and, you know, missing nurses, a pretty big omission, and pretty much everything else that matters. If we're to grip the crisis in the NHS, we need a serious plan for the workforce. And that's why I'm absolutely delighted working with Rachel Reeves, working with Keir Starmer. We've just announced today the biggest expansion of the NHS workforce in history, doubling the number of medical places at university, 10,000 more nursing and midwifery clinical placements every year, doubling the number of district nurses trained, and 5,000 more health visitors to deal with the dangerously high caseloads we see in health visiting. Taken together, this will show to an NHS workforce that is burned out, exhausted and demoralised that the cavalry is coming with Labour. And most importantly of all, it will show the public that in contrast to the short-termism of the Tories, who've run the National Health Service into the ground prior to the pandemic, Labour has a serious plan to rescue, recover and renew the NHS to make it fit for the future. The public know that without more doctors and nurses and healthcare professionals, they will not receive better care. There is no hope of reducing that NHS backlog, of bringing down waiting times and setting a higher ambition than the miserablest announcement we saw last week of trying our best to make sure people are seen within a fortnight, when the last Labour government delivered a guarantee GP appointment within 48 hours. That's just the start. We don't believe that pouring ever more increasing amounts of money into a 20th century model of care is good enough for the British people in the 21st century. That's why we're going to go further with a programme of change and modernisation that I'll be talking about in my speech on Wednesday, and no doubt Keir will touch on in his speech tomorrow. Because in spite of what the siren voices on the right of British politics are now saying, which is the NHS is unsustainable, an NHS that's publicly funded at free at the point of use is no longer affordable. It's not the funding model that's broken, it's the government. What I want to see change is the model of care that sees so much money spent in hospitals on patients' treatment because we don't get there early enough with early intervention, with prevention. And so we allow conditions that would cost hundreds, if not thousands, small thousands to fix, to become problems that cause tens of thousands, hundreds of thousands, even millions to treat, because we don't get there early enough. If you think about the flow of patients through a hospital and you think about the front door and the exit door, why is the front door to the hospital, the accident emergency department, overwhelmed? Because the front door to the NHS of primary care is broken. There aren't the people there to provide the treatment that we need. Why is it that so many people are in hospital, 400,000 or so cases of delayed discharges each month, where people are well enough to go back home into the community, but can't, you know, they're still there because we haven't got the social care in place. And, you know, this is worse for the patient, worse for their outcomes, worse for their care. And it's also more expensive for the taxpayer. So don't tell me that we can't afford a NHS free at the point of use that we built in the 21st century and the 21st, when we're squandering so much money on a broken model of care. And of course, it's not just about primary care, mental health, community services, where those district nurses are going to be really important, social care, which is important in and of itself, by the way, not just in terms of relation to healthcare, but in terms of people having a decent quality of life, a great quality of life, whether they're living life to the full, to the very end in old age, which I think are the group of people that come first to the mind in thinking about social care, or the working age disabled people who make up a quarter of social care users, and a majority of the budget, who have every right to expect a decent family life, employment opportunities, enrichment opportunities, a social life, you know, the things that make life worth living. It's about all of those things. But there's also a revolution taking place out there in terms of medical science and technology and innovation. And I want Britain to be at the heart of it, because if we are, not only can we ensure we do better and faster diagnosis and treatment, but actually we can do prediction and prevention. This has the potential to revolutionize healthcare in our country and ensure that in the future, we're not just living longer as we are now, although under this government, life expectancies begun to fall, which I think, I mean, it's rich pickings in terms of which indicator is most biggest indictment of the Conservatives, but life expectancy falling. But even when it was increasing, what I call quality of life expectancy has not kept up with life expectancy. And I don't know about you, I don't want to go anywhere anytime soon. Thanks NHS for what you did for me last year. But I definitely want to make sure I can live life to the full till the very end. I'm definitely one of these people who'll probably be still working and having hobbies late into retirement. And I want to make sure I've got the right support and healthcare available. So these are the bedrock of sort of Labour's thinking about health and social care. And, look, I think after 12 years of Conservative government, expecting them to fix this is like asking the arsonist to put out the fire they created. It's just not going to happen. And after last week's performance, I can think of no other explanation for the breathtaking display of recklessness and incompetence on display, except that maybe Liz Truss is still a Liberal Democrat and she's a deep state agent sent in to crash the Conservative Party. What other explanation is there for what we've seen and the budget that, even Conservative MPs are calling the kamikaze budget? It's just miserable, isn't it? And, obviously you were here, I was in the hall. Rachel Reeves' speech today, I think, set out, the kind of long-term plan and thinking that we need, the sort of thing I'm hearing from patients about what they want to see. They know there's no quick fix. I'm not going into the next election with the same old hackneyed cliched slogan of 24 hours left to save the NHS, because I can't fix it in 24 hours if and when we win. I am going into the election with very clear battle lines I'm establishing this week, but also a serious plan for the long-term future of the NHS, with patients at its heart, care users as its heart. Because, one thing I found when I became Shadow Health Secretary, there are representative bodies and voices for pretty much everyone who inundated me. But, present company accepted, because patient voices do a great job. I think we would agree that the patient voice, the care user voice, is still, despite best efforts, not heard enough loudly enough in the system. So I'm determined to be the patient shop steward and to be a real strong champion for both patients and care users. And I think after this conference, I hope that people will see the Labour Party is serious. It has serious leadership, serious team, and a serious plan for government, and will be reassured that the party that created the NHS for the 20th century can be trusted to reimagine it for the 21st century and build a national care service alongside it to provide a great workforce, providing great care to everyone, wherever they live, whatever their background.
Brilliant. Thank you so much, Wes. It always strikes me that where there are those naysayers who say, well, it's time for a social insurance system, it's always conveniently ignored that there are international systems that prove universal healthcare can work, and that never features in the argument. But it's out there, it can happen, it can be built here. So I think we'll enjoy discussing how we do that. Lots on the workforce, Sonia, and I might bring you in next.
I've just taken half my speech.
Sorry.
All right, good afternoon, everyone. So on Friday, I was speaking to the daughter of one of my patients, and she had visited her 82-year-old mother in the hospital the day before. She found her mum crying. Her mum had needed the toilet, rung the bell, no one came, and her mother had been left for over 2 hours in soiled bedsheets. Now, I mention this because I think often when we're having these conversations about the NHS, we're talking about waiting times, targets, but I guess what politicised me what I've increasingly seen over the past few years is the consequence of trying to deliver a service in unworkable conditions is that we are seeing compassion and dignity being sucked out of care. And I think the starting point of our conversation today has to be that it's just not good enough, right? It's not good enough that we have elderly people being left without dignity. It's not good enough that I have many children in my surgery with severe mental health problems, some of them self-harming, and they're not getting specialist care. Right? It's not good enough that over half of our maternity services in this country have been rated inadequate by the CQC. Right? So we need to understand that, and we need to think about where we're going forward, and we need to offer change. Now, just a couple of points that I want us to think about in our discussion. Now, yes, the consequence of that is Tory government underfunding, mismanagement, but it's not just money. And there is structural, and there is systemic, and there is cultural problems within the NHS that need to be addressed. Firstly, and I think this underlies the issues that you raised, that the NHS was created at a time when the population's health and their expectations was very different to what it is now, and there hasn't been enough transformation in how we deliver care. Secondly, I guess when we're talking about healthcare, we have to look at the health of our nation. And Wes was touching on this. Yes, we have this universal healthcare service, but we are called the sick man of Europe. Now, why is that? It's because a significant part of our population have poor health from a young age, and they are disproportionately in the more deprived areas of the country. And despite having this universal healthcare service, the health of the wealthiest in our society and the health of the poor, that gap is getting wider. And thirdly, as everyone has said, care, as you said, our care model is broken. And I'm glad, it's going to be politically difficult, and it's going to require some bold politics to rebuild our care system. But look, we can't call ourselves a civilized country when we have over 1 million elderly people who are not getting the care that they need and not being able to live with dignity, right? So the status quo is not good enough. We need to offer change, and we need to be ambitious, right? We need to have a positive vision for what healthcare can be in this country. And do you know what? I really agree with this. Like, there is so much potential that we have in the NHS that we're not using. Like innovation, for example, because we have this unified healthcare system, we have this massive, huge, rich amount of patient data. Now, if we have the correct legislative framework in place, if we're able to use that data correctly, then we could drive transformation in how we deliver healthcare. And then look, yes, health tech, life sciences, these are sectors in this country that are growing. Now, if we invest and develop these sectors, we increase the links of the NHS, we could become world leaders in how we deliver healthcare in this country. We need to meet the public's expectations. We need to have a credible plan of how we transform healthcare in this country, and we need to be ambitious, right? Our ambition has to be transform our healthcare system for world-class healthcare for all, and the bare minimum is to have a care service that allows people to live with autonomy and dignity. Now, neither of those things are being achieved at that moment. So we need to get Wes elected, and we need to deliver once we're in government, because we have a moral obligation to this country to deliver that.
Okay, we're slightly without sound, so apologies. I think the passion of your speech when it came through as much as anything else, so deep thanks for that. Julian, if you feel confident braving the lack of mic, come to you next to hear your thoughts.
Right. Okay. Put hands up at the back if you can't hear me as I'm running through this. Look, it's great to follow those conversations. My background, I'm a policy wonk by training, as it were. I'm also a repentant policy wonk. I spent a lot of time in my life dealing with spreadsheets and thinking you can find answers if we just analyze this situation more. And that is important work. But public policy is about the public. It's got to start there, it's got to work through, and it's got to find its solutions there. So what we've been doing at Engage Britain is essentially saying, look, 3 parts of what you do if you're creating good national policy. Local authorities do a huge amount of this automatically already. It's national government that's being so weak, and actually health has been probably one of the weakest. What happens if you start by supporting people to talk about what matters in their lives? If you then say, look, the next bit we need to understand is for the public, different views, different starting points, but what can we as a society get behind? What are the reforms that will actually have that political support to make a difference? And then finally, the really important bit, what actually works in practice? How do you make those changes? That's bringing people who use services together with the frontline are actually making them work. The employers, the commissioners in different parts. So one of the big things we've been doing is applying that and saying, look, what happens in health and care? If you take that starting point and work your way through it. And now, lots of my lines have already gone, as it were. I'm going to take you through a few of these. It's not going to be a state of big disagreement. There's 1 or 2 things where we might have discussion about. The first of, where's the public start? We get people together in open discussion groups to talk about health and care movements. The first thing they'll start with is the NHS and love for the NHS. And it is really love. But be really, really clear what people are talking about there. They're talking about the ethos that underpins the NHS. So it's that. It is the language of the 48 cent that comes through again and again. When people move on to talk about their experiences of the institutions that make up the NHS and all the things that they don't realise aren't part of the NHS but aren't, but they think of them as that becomes much more difficult for people, much less common. And particularly if they've got chronic health conditions. That being passed from pillar to post, not knowing where to turn, having to fight the system. And these are stories that are incredibly emotive of people who have, this is preventable harm. People shouldn't be left hanging on, not knowing where to turn. We took that language and we did some polling on it of the whole population. You get about 25% of people in this country will say they had to fight to get the care they need for themselves. That's about 15 million people. So these are huge, huge issues. What do we do about it, of course, is the next sort of set of questions. There's actually huge amounts of initiatives around the country. We've been looking at some voices have done loads of others, where people at a local level have sorted out what difference they can make. And this is not a patient versus staff thing. We have the staff in there who talk about being reduced to tears because they know they can't support people in difficult situations because they haven't got the resources to do it. There's very simple things that are going on in different parts. So Blackburn and Durham, they just training the reception staff to work in different ways. There's loads of stuff for people with higher need, connecting care for children with a GP in North West London, where GPs take a much more role in making sure care gets coordinated. Loads of those examples around the system. What we really need is how do you get the incentives in the system to start making those standards, not just working on what happens in. And that is where the national policy comes into it. It's absolutely vital. We're creating those incentives, not for a top-down solution, but to help people find those who support people. I want to just touch to some of the things that matters for a general public. I want to switch into social care because it's one of those issues everyone in this room knows, as Wes has said, the reason we can't get people through our hospitals to give them the treatment they need is because we can't move people out and into care. And we can't get them good care that stops them coming back again. Now, the reform of social care has failed so many times. And partly, I think, for me, it's because there isn't something that's resonant enough, a case for change that's resonant enough with the public. And I think we're on the cusp of change. When we were doing the deliberation work, so this is getting members of the public together, over a series of weekends, there was one, and I'm afraid it's only one frame that talks about social care that people came back to. They're interested in independent living for people. They're interested in how we live a good, frail old age, but they never really returned to those issues. But the reason we can talk about it in questions is people are interested. They came back to carers. How do we get enough carers into our system? And they didn't mean just someone just doing a job. They meant people with a vocation for caring, being allowed to work in a way that builds a relationship with the people that care about them. And we've done a load of work around here. Well, how do you do the messaging? How do you make that up? Unless we have a clear, compelling, it is more carers helping people to come through. You may have to connect that to the NHS story. That really annoys some people who campaign for social care because they're so right. That social care is much greater than discharge from hospital. But unless you give something a route way in, you can't get people to follow on to that story. So we have to do something. Third thing I just want to touch quickly on is just, well, what's that look like when you do it? And we've been just getting together a group of people, use social care, people work in social care, employers, providers, and some experts from the Nuffield Trust who've been helping us with this, to come up with, well, what does it look like if we really value carers? And some of this is almost cost-free. So the green badge scheme, for example, where we would allow carers to actually park near to the people they are caring for, a little bit like blue badge scheme disability. It's practical, but it also signals a society cares about this. Having carers genuinely involved in talking about the treatment and the support packages that are going to the people they're caring for, which so often doesn't happen, almost in a shocking way if you're used to the NHS. And there are things that really cost money. There's the standard, how do we get progression in? How do we do that? Now, the key thing in that is not just qualifications. If we let DFE run this, it will be a qualification. Please go into a classroom or we'll give you a sheet of paper. It's experience as well. How do we reward experience for people who may not want to go down those more specialist routes? People who are working as personal assistants, for whom the relationship with personal care is central. And there's pay. You can't get away from it. The key thing is this is not pay as a minimum wage floor, because that's a sort of negative thing about it. It's pay as a parity of esteem with others doing caring work. And what does that mean? Right? What are the institutions about? What are the stuff that needs to implement? Final thing I just wanted to say on this, and we've touched on it a little, and actually it's very outside because you've got the announcement now about workforce. The number one thing that the public will come to, and the point that you won't really get them wrong, you might be able to hear me again in a second, is essentially, how have you got enough people working in healthcare, enough nurses, enough doctors in hospitals, enough GPs? It is obvious to people that we do not. And it is a chronic problem of our health system. Unless our political system can solve it, how will you get people to believe in our political system? Now you can talk, Charlotte's quite right, exactly replicating the exact ways we did things in the past is not what we should be trapped into with that. And Wes, the announcement today, I'm sure will be very welcome for so many people of a commitment to more training and more places. But I think we actually probably need to go further. In lots of areas, the promises of investment in future workforce happens, but then there's a short-term crisis and those funds get raided. And that's not a bad thing, people doing bad things, it's just the nature of a long-term investment that you need to make. In lots of other areas of public policy, we started not tying the hands of politicians and decision makers in health, but supporting them to really make those changes. So what could we use? What are the independent ways of saying what workforce do we really need? And how do we help politicians make the case for this is the type of training that creates more flexibility in return for the resources that put in? So there's a load of sort of institutional things we could do. We do them in areas like the environment, we do them in areas like fiscal policy. What could we do to reassure the public that this is not just an announcement, this is a commitment that government will hold to? Finish there. Brilliant.
Thank you, Julian. I think we've heard some fascinating, unified by their optimism, visions for the future. It can get better, we can achieve more. I'm going to come now to your questions. You can have a turn at amplifying your voice as we've been doing. I'll take them in waves of 3 and then we will come back to the panel and we'll go like that until we run out of time. Yes, gentlemen at the front.
Hi, Margaret. I work for an organisation called Dimensions who support people with learning disabilities and autism right across the country. Just one thing I'd like to mention, back in 2018, we launched a campaign called My GP and Me, So my GP was to train GPs, doctor receptions and that, to learn about how to support people more within the surgery, reasonable adjustments, more time, or somewhere place to meet in the surgery, so that we can't actually, as well speaking, so the person can speak to the person who is coming to the appointment, places where he could relax. And like I say, we since 2018, we've done it absolutely free across the country. So but also we've done a lot of lead work around health and well-being. We've done lots of work around health, so that people understand. But yeah, I think the issue we've got, communications between the hospital and the homes when they are discharged, that's still working really well. So yeah, I mean, it's tough in some areas we've seen, and also just around, yeah. So, and we do a lot of easy read stuff as well.
I think questions of communication with discharge that I'm sure we'll have reflections on. Anna.
Hi, it's Vera from Impact on Urban Health. We're one of the UK's largest health foundations. We work in Lambeth and Suffolk, but our learnings about ID cities across the UK and the world. To Charlotte's point about dumb questions, apologies for it, but this question is simultaneously really exciting, and I've got loads of support, loads of the ideas spoken about already, but also, is it the wrong question to be asking? Because as alluded to, we know people get sick in places that aren't to do with the health service, so it's people's employment situation, it's night shift work, it's the air they're breathing and the food they've got access to. So how do we shift the conversation once we have the workforce we need in the NHS and the access routes in? How do we shift that conversation to what can we do outside of that service? So for example, one of our initiatives we're working on at the moment, we know financial precarity triggers ill health and possible ongoing resistance. Shield uses GP practice lists to link up with secondary social providers and financial support, and that's been shown to save people £2,000 a year when their health crisis is happening. So how can we embed that sort of thinking where we're joining up the services?
Really good question. Thank you very much. Hey, with that, you might get your seat back in the second one.
My watchman's telling me to stand up anyway, it's fine.
Gentleman in the middle at the back.
Thanks. Really moving now. I got the tail end of the deliberations, so this may have been covered, I don't know. But the idea of developing a national care service, or indeed continuing in
Yeah, sure. I will take all of those questions. The question about handovers, discharge, I think this ties into two things. Partly it's cultural and about how decisions are made and in whose interests. You raise discharge. I also think about arrivals and ambulance handovers. Why is it that there are some hospital trusts who rightly, in my view, in a very patient-centered way, say the moment the ambulance pulls up outside the hospital, as the hospital trust, that's now our problem. We need to get them straight off the ambulance and we've got to deal with them because we've got to get that ambulance straight back out in the interest of other patients. And yet in some other trusts, I'm afraid the attitude, for reasons I do understand, because the pressures they're under, but the attitude is, oh, we don't want to take the patient in because then they become our problem. At the moment, they're the ambulance services. That's what I kind of call classic producer interest. I understand the pressures they're under, but the driving interest there at the heart of decision making is not the patient, it's risk aversion for executives. That's not acceptable, and I have no time for it. And similarly with handovers, I think that's possibly quite partly cultural, but also about systems. I think a test for the new integrated care systems is whether they are able to genuinely join up services, so there is genuine partnership. I started out in this job open-minded about integration of health and social care, insofar as there will always be people who say, take social care, put it in the NHS, have a national health and care service. And I'm increasingly of the view that that would be a mistake. We're talking about quite different things in terms of the health service and the care system, which is why I talk about a national care service alongside a national health service. I think they're different. And similarly, when I talk about a national care service, I don't mean centralised, top-down, one size fits all. I mean national standards and expectations, national standards in terms of pay terms and conditions and career progression for staff, because without that workforce, which the public recognise, we won't recruit and retain the brilliant people we need. And these are highly skilled jobs. These aren't care workers, these are care professionals. The work they do is highly skilled and highly, I think highly demanding, and we should recognise and reward it as such. In terms of my GP and me, in social prescribing, I'm a fan of social prescribing. I like that kind of join up, but I get slightly nervous when we start to think about, the NHS. Gordon Brown, who I have a huge respect and admiration for, is so aghast at what's happening in terms of poverty in our country. He said, well, look, maybe the NHS needs to start prescribing cash for people's heating bills. But I don't think the answer to where we are now is because the Tories have run down the welfare state. The NHS becomes the welfare state. We need to, reintroduce prosperity in our economy and help to tackle poverty and inequality and make sure we don't create the conditions for ill health. And I'm disgusted, frankly, that healthcare professionals are having to pick up the pieces for the wreckage around them in terms of what the Tories have done to our public services and living standards. And finally, it comes back to the point I made in my speech, actually, about the central principles. I think the idea that we could afford a national health service free at the point of use on the principle of equity and on the basis of need, not ability to pay in the 21st century, but now we can't in the 21st, is absolutely reprehensible and completely unsupportable. Things should be getting better in our society and more civilized, not worse. And Bevan called the NHS the most civilized thing in the world, and I think he was right. So our job is to make sure that we retain the NHS free at the point of use, and that will come partly with the investment we've been announced today and partly through change and modernisation. And finally, in terms of social care, and going back to the National Care Service principle, we will get to and deal with, and we've got the Baby Society doing some work for us at the moment towards a National Care Service, the issue about the burden, the financial burden that people face, because we've never had free universal health social care system in this country, and there is a disproportionate burden falling on people, and people are being left behind, and we need to deal with it. We have said this week that we will clamp down, particularly on, but not just, the private equity-owned care homes who are providing shoddy standards of care and extracting millions of pounds out of the social care system. I don't like the profit motive in public services. I think the profit motive is antithetical to the delivery of public services. That doesn't mean that no one involved in sort of the infrastructure around public services can't make a profit. There are plenty of technology companies whose research and innovation is absolutely essential to building what we want. There are plenty of, you know, think about other public services, you know, look at Pearson and their learning resources. You know, they provide a great resource to the education system. So that's really not what I'm in, you know, not really interested in that. I'm interested in making sure that, you know, the public services themselves are not for profit and focus on, most importantly, the needs of the patient, the pupil, the care user, the users of public services. And in social care, I would just kind of conclude by saying, you know, I'm keen to get after bad practice, but I'm not interested in nationalising good practice. There are some brilliant people in the voluntary sector in particular who do a great job, who are arguably more innovative, more responsive, and more listening, and we could learn from them, you know, and raise them to the game of the state rather than the other way around.
Thanks very much. Bring you in next to you.
Right, thank you. So just two things I wanted to pick up on briefly. I mean, Wes has covered a huge amount in his answer. One was just this thing about health versus treatment. And I mean, people will know in this room, you know, treatment is a tiny part of good health. The thing to really have in mind is, where is that consensus from the 1940s? It isn't a consensus about equality of health, even if we might want it to be. It isn't. It's a consensus about access to treatment. It's that fear of finding you or your family are ill and cannot get treatment for it. That's what people drives them, really motive. There's a little bit, when you do this in discussion, parts of the political spectrum thinks in terms of health inequality and inequality of outcomes, and we should have equality in that. And that's quite contested in a discussion, because it would just run up against, look, that's a whole set of people's choices. Now, many people in this room will find the notion that, you know, actually your choice to smoke, your choice to you know, drink more, etc., are not independent choices. They're choices that are created by social conditions. But there's a lot of people in the electorate for whom that is a connection. So if you want to argue health inequality, by all means do, but be aware that a lot of the population will do it. If you want to get a specific change, you want to get people really behind it, think where that inequality becomes an unfairness of access to treatment. And if you can make that access to treatment argument, it'll be a hell of a lot stronger than an inequality argument. That's not to say the inequality arguments aren't valid, they are. That's the people's fault. The other thing I just want to pick up on was the tax point. Love the NHS is absolutely there. The easiest conversation to trigger with any group that I've worked with is about how we fund things going forward. Free of the point of use is fundamental. People aren't fools, they know it's an aging population, they know it's going to cost more, whether it's health or care. They know that means taxes are rising to fund that ultimately. And they actually, you know, as I say, 2 to 3 minutes in any discussion group, we'll get that conversation to that point. Who gets taxed, how they get taxed, how it operates, whether this looks like something a bit more like social insurance than whether it looks like something that's just general taxation is an issue for discussion. The one thing in that wasn't in the health and care levy, that came in and then got abolished under the current government, it's broad shoulders. It's business contributing, it's a collectivist, corporatist idea that comes through, and it's those who have the most wealth making sure they're contributing a proportionate share, or possibly a disproportionate share, and in your politics. Those weren't characteristics of the health and care levy. If you were thinking about that conversation, I would encourage parties and opposition to ever talk about tax numbers. It did, well, it did in 2001, it wasn't done in 2019. But that is a very easy argument for, because people believe, as you were saying in your question, they believe in that freedom and point of use and an offense. They understand the consequence of what that means for agencies.
And I should have added earlier, the workforce announcement we made today is going to be funded by the reintroduction of the top rate of tax on the highest earners. And, you know, talking to some of those highest earners, including some of them who are here supporting the Labour Party this week, I think they would agree that it's money well spent, and we need that money more than they do.
I'll go from right to left now and bring you in, Charlotte, for some thoughts.
Yeah, I sort of feel passion around the distinctive financial taxation argument, and you know, I'm not going to argue with that. I just think we mustn't kid ourselves that this health system, despite being free at point of use, delivers equal outcomes. It doesn't, and I think the reason it doesn't is what Anna said. about health too often being blind to context. And that's to do with the medical model and somehow believing that, you know, we're dealing with bodies when actually we're dealing with people, and we're dealing with people in the context of their lives, and it's often their lives which are complicated and make them ill. And that takes me to the point that Mark raised right at the start of the question, which is we need partnerships where the NHS gets into conversation with people who know their situation best. And that's Mark and his mates who know the situation of people with learning disabilities who want to use health services the best. And that's the members of National Voices, that's Positively UK, who know what it's like to live with HIV, and who know how the people who catch HIV now have changed, and who understand what is needed to prevent this virus being passed on. And it's a small charity in Liverpool. They work with women who've experienced genital cutting and who advocate for those women in gynecology and obstetric services. We need to get the NHS comfortable working with people who understand the context in which people's lives plays out, because that's communities and their organizations who will always ever talk about health in the context of life. And I think there's something really there, rich seam for us to connect progressive politics on the NHS with progressive politics more widely. Because if we believe we want a health service free at the point of use, we need to show an interest in whether people can turn the heating on in the winter, whether people can feed the children, and whether people can access education. And if we don't show an interest in any of these things, we won't be able to afford health service free and on use. And I think we can connect that in arguments that feel comfortable to people who come from the social democratic tradition, but also make sense to people who think and feel more comfortable with the language around prosperity and productivity and health as well. And I think that's the thing we've got to strengthen in our arguments around NHS reform.
Brilliant, thanks very much. I strongly agree with those points. Sonia, what do you think?
Yeah, I just cover quickly so much has been said. Mark, thank you for making that point. And I think it's a really, really important point. And I think what you're saying is actually we need to remember that it's not just, we often think about doctors who provide healthcare, but actually you're right, it's the secretaries, it's the nurses, the healthcare assistants, it's all these people in the service that are there to provide that care. And I think the second point, what you're saying is completely right. Like actually, everyone that should be coming into service should have time, should be able to access the service that's comfortable for them. And I think the problem is because we're so just firefighting constantly that we're not providing that holistic care, which you're completely rightly saying is needed for everyone. And just another point I want to raise about people with learning difficulties. You know, in my area that we work in, our learning difficulty service has been completely decimated. We have one doctor covering the whole area. And there's about 1 year waiting list now for young people to be diagnosed with learning difficulties. And then when they have a health problem, I will refer them, and then it will be another 6 months before they're seen. So I think it's actually quite shocking that we are letting down children and also adults with learning difficulties and not getting the care needed. And it really is something that needs to be raised upon prominence politically. And then just as Anna, your point about really, really good point. And I work in Tottenham, and it's really fascinating because we're a very big practice. We've got about 4 sites, and we've got this new site. So there's like one site where I'm mainly at, which is called Old Tottenham, Real Tottenham. And then there's a new site where there's some new build flats near the canal, very nice flats. And my day that I spend there is just an amazing day, such an easy clinic. And the conditions that my patients are coming to me with are just completely different to the rest of my week. You know, the health is completely different, and it's shocking. It's like literally this clinic's about 5 minutes away from each other, and the health of these two populations is so different. So you're completely right. And I think, you know, I don't think the NHS on its own can address that, but it's across government priorities that needed. Actually, Gordon Brown, you know, this was started under Labour. Gordon Brown set this commission to try and reduce health inequality. Obviously, got slashed when Tories came in, but there was improvements in health inequality under New Labour, and then that has now started to reverse. But we do need to be sorting that out. And then just at one point about social prescribers. So in my clinic, you know, particularly in our main site, I'd say maybe about a fifth of my patients are presenting with social issues, whether that's housing, whether that's access to benefits, and our social prescriber is the most busiest person in our clinic, and actually it's the 3rd one that we've had in 3 years, because the workload is really unsustainable. And I think, yes, social prescribing is good at connecting services, but I what Wes says is correct, but actually I'm also a bit uncomfortable with it, that the NHS is increasingly having to step in for a failing welfare state. And actually people shouldn't have to come to their doctor to get food vouchers. They shouldn't have to come to their doctor to say, I'm being evicted, what do I do? And we need to be building out a welfare state. The NHS can't be doing that.
Can't get to see a doctor.
Yeah, well, that's also a big problem.
Aware there were lots of questions, so I'm going to take another round. We don't have ages, so punchy questions, punchy answers. Go ahead.
The Tories have turned it into the National Health Service, and I've looked after my husband for 10 years who's got Parkinson's disease. I've never ever claimed carers allowance until 2 appointments a year, got on with it, got the medication, looked after him when he had slipped discs and bound for 3 months, lifted him, moved, handled him, washed him, dressed him, fed him 3 meals a day, and all the rest of it. And when I needed help last year, it wasn't there. The GP didn't want to know. He passed it on to neurology. Well, in August, neurology get all these robot messages about COVID, answer phones, being bounced around secretaries. And he knew he had an emergency phone number he could have got. He was out before. I had 70 odd nights of no sleep. He's wet in the bed. And the ambulance would not take him to A&E because these privateers were coming, and they're not proper NHS paramedics. What was called Spark Medical. I think they must be on target. This took me, started with dementia, he was violent and aggressive towards me, locked out the glass shower door. And then I had to fight with him with the drill and didn't want to know. And I documented it, put it all in writing to neurology. In the end, I had to write to my MP to get seen. Within 2 days, I saw him, the neurology, what were you doing, laughing at me behind the mask, because I was so stressed, so anxious. Once when the paramedics came, I said, I'm suicidal, don't take the middle all night, got angled down one side of his body. They rang the GP, the ambulance was parked outside my house for 2 hours because they couldn't get hold of the GP. And I took her name and over to his. And when they got hold of the GP, his numbers are right. You know, she did refer him to a physiotherapist. All they've been doing is GP social prescribing, it's for birds, totally useless. And anyway, they were just passing the book on to physiotherapists who were light years away from the problem. And in the end, I got him in respite, an expensive place for a week, and they wouldn't take him. When I got there, the matron refused to take him because he was psychotic. And the nurses can't cope with him. I said, well, I can't cope with him. I said, right, tell me what I'm going to do. I'm going to take him to the police station. I said, get in the car. We're going to the police station, and the house is full of dangerous drugs, and I'm going to tell the police that I'm going to overdose him. And I said, he's carrying on, shot to me. He said, really, really, really embarrassing. This is in the reception of the hospital. And I said, listen, I said, I'm going to be on the charge. I said, they'll pick you up, they'll find out all the drugs in your body, they'll know it's me, you'll be dead, and I'll be in jail. And next thing is, big social workers turn up. And then got home to the GP, and because his back was against the wire, he got in after admission out of the house away from me. And then, when he's in hospital 6 weeks, I tried to block them. Sent him to 2 disreputable nursing homes, the records 2-star reviews for malnutrition. So what they did, behind me back, told me this afternoon, they sent him in his pajamas to a care home. I fought against them sending him to a residential home. He's being in a nursing home because Parkinson's complex illness, and they sent him to a place where he wandered around feeling, and they told me, and this social worker rang me and told me when I was crossing the road on a winter's afternoon, I still come across a busy main road again, and she said, oh, it doesn't matter. She said, you haven't got lasting power in attorney, and he hasn't got the right to reside in a hospital. So they've done it on the slide, they sent him to a place I've never heard of. In his pajamas, was all his bottles got stolen off the wall. All his clothes that I provided, I wrote to the chief constable and Merseyside about it. So how
I think,
do you stop them passing
I
the
think
buck?
it's a tragic story of how it's.
Discharge team, not people. And I warned the GP that he was going to have a catastrophic injury. I read 7 emails, he ignored them all through December. The staff said we're not insured for him. The 2 women staff can't lift him. I said, well, don't pin it on me.
Yeah, I think.
I mean, he fell and broke his head, he's dying now.
It's
He was in hospital, they sent him right through the revolving door, right back into training, into an on Boxing Day, an expensive operation, and 12 weeks where I had to go in and do his personal care and that. He was 80% dependent when I had him at home on Christmas Eve, and now he's 1000% dependent on other people.
It's a tragic story of how things go wrong. And I think, Julian, you were going to.
Well, the thing, I think the thing that is most shocking listening to that story, and I'm sure Charlotte will say the same, it's not the first time I've heard a story like that. Things happen. How we deal with that, and how. I mean, I'm sure Sonia will want to come back on this from the south side, but you know that is the illustration of what happens in this country, and it is also tragically something that people will use against the NHS. It can't deliver, and therefore we have to change its funding and how it operates. The answer is we have to get a patient system that works around people and supports them, and we have been passing them.
Yeah. Any views that you want to bring up?
Well, my heart goes out to you. It sounds absolutely horrifying. I remember my husband lost his mind towards the end of his cancer journey because it affected his brain, and I could not find a place to look after him. And we were having a conversation in the hospice, and there was a doctor, a nurse, and a discharge manager, and we spent an hour deciding what we were going to do. And I said to them afterwards, that must have been a very expensive conversation. And they said, but everything else would have been more expensive. And I think that's the thing we've got to do when we're dealing with complexity. And that's just a complex situation, someone deteriorating mentally and physically. We've got to bite the bullet and have the conversation about the complexity beyond this is your bed, this is your bed, this is not my bed, and this is not my bed. Ultimately, we waste huge amounts of money treating people like that. But more importantly, we drive carers mad, and people lose their dignity and their lives. So there is no shortcut to quality care.
Sonia, any thoughts from you?
Yeah, just, you know, it's just heartbreaking listening to you, and the system has failed you. The system hasn't been there for you and your husband, and you're right to be angry, and we should expect better from the system. I think you've also raised an important issue of, you know, you said your husband had Lewy body dementia. So this is, you know, a form of Alzheimer's disease with fluctuating cognition. And I think there's a real problem. We are all living longer, but there are going to be more increasing years of our lives where we're going to be declining functionally, physically, or cognitively. And we have to have a system that's able to support people in those, it could be 10 years of their lives. And it needs to be able to allow people to live with autonomy and dignity. And that's, I think, why you're so angry, right? Your dignity was taken away from your husband, and that's not acceptable. And you, absolutely, yeah. Yeah. Yeah.
You know, like what's these people, because I have no way out.
And I think, well, it's whereas I think it's a story that leads to a final word, perhaps from yourself. Conscious of us being in time, but do you have a final word?
Yeah,
based on what you've heard.
Yeah, I mean, I've been thinking about and talking about your horrific case since we bumped into each other the other day. There are so many individual things that have gone wrong which speak to much wider problems, you know, contained in that story, as you said, is not getting there early enough with the intervention, not listening to the needs of the wider family, and not simply to the patient, the lack of any real joining up of all of the different support that your husband needed, which was partly different medical interventions and also care interventions. And of course, the fact, as you mentioned, in addition to failing your husband, this has made you unwell. And that's deeply unfair and unjust as well. And it goes back to something we kind of touched on sort of earlier in the discussion, something Julian mentioned in the research that Engaged Britain have been doing about the numbers of people in our country who feel like they have to battle the system. So not only are they dealing with a really stressful situation, either in terms of their own health and care, or the care and the health of someone they love, but they are having to additionally deal with battling a public service which should be there to help and serve them. And you know, I think it underlines the sort of the scale of the challenge, really, and why you know, we need to kind of fix the whole system. Unless we take a whole system approach, it's not going to work. And I'm glad you're battling and complaining on your case. I know your MP's on your side as well. Yeah, but we need to learn from these cases. And as other panel members reflected, I wish we were all sat here in shock and horror at this unique case. We've never heard of something like it before. But we do. I see it in my own constituency casework. You know, I hear it from other MPs and what they're up against, and I think it shows how fundamentally badly the system's been broken, and why we need to not just sort of rescue and recover the system to back. You know, I'm not interested in building back to where we were. That's why I talk about an NHS and a social care system that's fit for the future, because at the moment it's certainly not fit for today.
I think that's spot on. And a summary really of both the challenge that we face, the severity of it, but also in many ways the opportunity of how much better it can be. And I think if something's unified responses we've heard through the panel, to me, it's been that sense that better is possible. It takes a lot of commitment, it takes a lot of work, but it is possible. I think that is probably the note to end on. I think we've hit time. I know from an IPPR perspective that we are planning to do lots more on this. We have our Commission on Health and Prosperity. One formative mission of that is to think about what the next steps are in the NHS. We have our own patient-led panels working through that over the next 3 to 4 months, and a plan scheduled for next year. I know others on the panel are continuing the work to outline what that looks like. And
I'm very much looking forward to reading it. I hope you're gonna have some good ideas in there for us. It's been challenges.
I hope so too. I hope so too. A huge thanks to Wes, to Julian, to Sonia, to Charlotte for sharing their huge expertise, their thoughts. A huge thank you to everyone for coming. It's been brilliant to spend with you. We'll see you all again soon. Thanks very much.